Good afternoon, everyone, and welcome back to the fourth installment of our video recorded training sessions that we're providing for our cohort. Today we're going to be talking about adult dehydration, and we're going to focus on that specific topic, but also the importance of assessment, critical thinking, and communication with this topic and kind of in general as well. My name is Jack Jager. I'm the Executive Director of the RIC Simulation Center, or the Rural Health Innovation Collaborative, and we're pleased to be with you again today. We'll have a couple of folks that will be involved in this training outside of myself, really more them than me, Laura Livingston and Suzanne Wheeler, and we'll be talking to them here shortly. As you know, if you've been on any of the trainings up to this point so far, we are recording this. So for your purposes, you can be watching it now, but you can also watch it later and share with your staff, anyone within the hospital that could use this kind of training. The primary points of contact for the RIC are the three folks that I mentioned previously: myself, Laura Livingston, who's the lead clinical simulation specialist at the RIC Simulation Center, and Suzanne Wheeler, project consultant for the RIC and a clinical nurse specialist. As I've mentioned before, this is a program that is part of the Indiana Hospital Association SHIP grant, which is the Indiana Small Rural Hospital Improvement Grant. This is a 4-year project, and the RIC has been contracted through the IHA to provide simulation-based training to promote patient safety. And this is our last week with this cohort, and we will begin our new year starting next week with 9 new hospitals around the state of Indiana. So we're excited about that, and sorry to leave our old cohort behind. As I've mentioned, the partners within this project, really we're a contracted organization for the Indiana Hospital Association and the Indiana State Department of Health through the Office of Rural Health. And so this training is provided through those entities. Today's agenda is similar to our previous trainings. We will start with a pre-course test that we really need for everyone that's on the call today to take, and everybody who ends up watching the video recording at a later date to take the pre-course test, and we'll show you the link for that, the QR code to get into the pre-test. We will then go into some virtual trainings with embedded debriefing, followed by a presentation on adult dehydration from Suzanne Wheeler, followed by a post-course test and a post-course evaluation. So here is the link for the pre-test. You can either go to the link provided right here, or you can use your phone, smart device, to scan the QR code on there and then take the test. As we've done in previous sessions, we're going to give you about 5 to 6, 7 minutes to complete the pre-test, and then once we're done with that, we will come back and start the presentation. So at this point, I'll go ahead and pause, allow you to take the pre-test, and we will see you again at, let's say, about 11 or 12 after 1 o'clock. All right, I think we'll go ahead and get started again. So next up is our lead clinical simulation specialist, Laura Livingston. So Laura, if you're ready, go ahead and take over.
Hello, everyone. As JJ said, I'm the lead clinical simulation specialist for the RIC Simulation Center. And when we were asked to do this topic, it was about adult dehydration, but as a bigger part of it, we realized it was more about the assessment of patients and the critical thinking that goes into the care of the patient, and then the communication of the patient's conditions. So what we're going to do is we're going to watch certain video clips, and before and after some of those clips, we are going to have some discussions. So for that to occur, I'm going to need audience participation. And I noticed that some of you do not have microphones hooked up. If you have the ability to If you have the ability to hook up a microphone, that would be absolutely fantastic. If you do not have the ability to hook up a microphone, then you can use the chat function. There's going to be questions that I'm asking, and you can answer them in the chat. I'll voice them to everybody, and then we can have a discussion. So we're going to go ahead and get started. Next slide, JJ. Okay, so our patient today is 67-year-old Sandy Withers. She's a resident of an extended care facility. She's admitted 7 months prior for rehab following a CVA. She has left-sided residual and dysphagia. She begins the scene in her room at 8 o'clock in the morning.
Sandy, it's Carrie. How are you this morning?
Tired.
How are you? The CNAs told me that you didn't feel like getting out of bed this morning.
No,
All right.
I'm too tired.
Well, we can't stay in bed all day, so let me help you get up for a little bit, okay?
If I have to.
I'm gonna give you your glasses, all right?
Yeah.
Just so you can see.
Thanks, dear.
Marianne was missing you this morning. She said you guys usually watch the Today Show together. She had to watch it by herself.
Yeah, I'm just too tired.
Just too tired. All right, I'm gonna put this underneath your back, okay? Oh, sorry, there we go. All right. Sorry about that. Okay, we'll get this wrapped around your waist. Get you up and going for the day. All right, I gotta take your blanket off just for a second, okay?
Okay. It's always chilly in here.
It is.
I have a few.
All right. Now I'll take care of your left leg, okay?
Okay.
Get you all covered up. There we go. All right. You good sitting on the side like that?
Yeah.
Okay.
Could you hand me my lipstick, dear?
Yes, absolutely. There you go.
Thank you.
You're welcome. And then do you need some new underwear today?
No, I didn't go.
Okay.
Okay, so is there anything that any additional information you'd like to know about Sandy? Anybody? Anybody? Sarah says she would investigate a little bit more as to why she's so tired. And she didn't sleep well because of what? Did you notice anything that may be abnormal for Mrs. Withers? Her nurse happened to say that she always watches the Today Show with her friend Marianne. And for some reason today she's not. Someone wants to know, when was the last time she voided or drank? So that's a very good question. Mrs. Withers has a PEG tube and she does not take anything orally. And Sarah says she looks pale, her lips were dry, and she needed her lipstick. Those are all very good observations. Notice her nurse asked her if she needed any new underwear or Depends, and she said that she didn't go. So that tells us that potentially it may be a norm that she maybe needs a new Depends in the morning, and today she didn't. So as a nurse in the extended care facility, is there any alterations that you think that should be made in her care at this point? if we were not in a presentation for dehydration right now, do you think anything would be changed? Alyssa says that we should be monitoring her INO. Maybe just even more general monitoring of her, a deeper assessment of things. So just watching her a little bit closer. Hey, Miss Withers. Can you open your eyes for me? There you go. Good job. What brought you into the ER today?
Hurts.
I heard you fell. What were you doing when you fell?
Thirsty.
You were thirsty? Were you trying to get a drink?
Yeah, I was going to the kitchen.
You were going to the kitchen, okay. All right, dear. Can you tell me what hurts?
My hip.
Your hip?
My arm.
Is it this hip?
Mm-hmm.
This one over here?
Mm-hmm.
Okay. We're gonna check that out, okay?
Mm-hmm.
Oh yeah, you got some bruising. Does your knee hurt at all?
No.
No? It's warm. I'm gonna take your socks off, okay?
Okay.
Let's pulse here. Weak and thready. Looks like you've had your nails done. Oh, looks like you got a cut on your arm over here.
Do I? It
Can-
hurts.
Yeah. Does your elbow hurt when I touch it? No, okay. I'm gonna take a look at your belly, okay?
Mm-hmm.
You got a tube here in your belly.
Yeah.
Is that how you get all your food?
Yes.
Yeah. Do you take anything by mouth? Do you get any food or water by mouth?
No.
No? Okay. Miss Withers, can you tell me where you're at?
Doctor?
Yeah, you're at the doctor's. Just gonna look at your eyes here. All right. Can you follow my finger for me? Can you hold your head real still? There you go, look at my finger. Good job. Do you know what year it is?
2019. No, 2020.
2020, yes, you are correct. Can you tell me who the president is?
Donald Trump.
That is correct. I'm gonna listen to your lungs, okay? Just gonna take a listen to your belly.
Okay.
you get breakfast this morning?
I think so.
All right, dear. I'll tell you what, I'm gonna get a dressing and cover up this arm here. And we're gonna have to start an IV in your other arm, okay?
Okay.
Miss Withers, has anything made that pain worse?
Touching it.
Touching it? What about better? Has anything made that pain better? Just gonna measure this wound here on your arm, okay? I won't touch it. About 3 centimeters by 2 centimeters. We're just gonna set that on there until the doc can see it, okay? All right, we're gonna start that IV in your arm. One more measurement here. I'm gonna measure this bruise on your leg. It's quite the big bruise you got. Do you know if you hit your head, Miss Withers?
I don't think so.
You don't think so?
I don't know.
Does your head hurt? No. If you had to rate that pain for me, with 0 being no pain at all, and 10 being the worst pain you've ever been in, could you rate it for me on that scale with a number?
Bad.
It's bad. Okay. All right, honey. Be real tight here for a minute. Look at your veins here. All right, real cold. Just a second. All right, dear, you ready for a big stick? Here we go. Big stick. I'm sorry. Oh, darn. didn't work out for us.
Mm-hmm.
You doing okay?
Mm-hmm.
I'm gonna go talk to the doctor, see if he's ready to come in and see ya. Okay. Put this rail back up. Couldn't even get you to bleed. All right, write down those measurements here. Just a second. Carrie, can you help me? I want to take a look at her backside. Doctor's not quite ready yet. This is Carrie. We're gonna roll you on your side so I can take a look at your backside and make sure you don't have any wounds back there too, okay? All right.
Well, Mrs. Withers, I'm gonna help Laura, okay? Wanna roll her towards me? Or your way?
Let's roll her. Can I come on that side and
Yep.
roll her this way?
Yep,
She has a hip and an arm.
Oh, okay.
Let's put this pillow between her legs.
I'm gonna take one of your pillows out, okay?
You still got one behind you. You okay?
All right.
Just tired.
Just tired? She's got.
Ouch. What'd you do?
So there's when we roll that way, you're gonna have a pillow between your knees, okay? Try to keep that hip from moving. All right?
Can you help me with my leg?
Well, I will. Yes. Let me lift this up so she can hang on to it. She's had a stroke on this side, so she has a weakness.
Okay.
And she does have a wound underneath. Just right here.
All right, so you're all sorts of banged up, aren't you?
She says her elbow doesn't hurt bad.
Okay.
I'm gonna lay that right there on your belly, okay? Carrie's gonna put her hand back here behind your shoulder. Your
Okay.
shoulder's not hurting at all, is it?
No.
Okay. And I'm gonna lift underneath you.
Oh, this way,
There we go.
girl.
Now, how's that feeling?
It's okay.
It's okay? All right. All right, I'm gonna listen to your lungs back here, okay?
You doing okay? Okay.
Deep breaths for me. Good job. She does have stage 1 pressure ulcer on her coccyx. About 5 centimeters by 4. All right, hon, we're gonna roll back this way now. All right, I've got it. Good job. Good job. You feel like you're high enough in the bed?
I don't think so.
go ahead and get this leg up on this pillow. Okay. There we go. All right. Go see if the doctor's ready to come see you, okay? Let's see if we can get you something for that pain. Okay. We'll put that real one. Okay, so let's talk. So what was abnormal with Miss Withers' assessment? She sounded very weak. And yes, she was very tachycardic. I don't know if you could see all of her vital signs very well, but her heart rate was in the 130s. SAT was 98. Her blood pressure was low 100s, over 70s. Respiratory rate was in the 20s. And temp was 97.8. Anything else that was abnormal with her assessment? At times she looked like she had an increased work of breathing. Okay. Yeah, she was breathing in the 20s. As I was sitting here watching it back, I was thinking laying flat may have been hard. It may have been hard for her to breathe. She also had a slightly decreased pulse in her affected leg. Her pulse in her left foot was weak and thready. Her skin was dry and her mouth was also dry. She had greater than 3-second capillary refill. As someone mentioned earlier, she looked pale. She was very warm and pale at this time too. She was still very alert and oriented, but kind of lethargic. Is there any information that you would have liked to have gotten from the extended care facility? Current medications, great. Was she found down or a witnessed fall? She was actually found down. That's great information. Baseline vitals and level of consciousness, great. Any history of UTIs, general mobility, history of stroke. Brad, she did have a history of stroke. She has left-sided residual from that stroke. No history of UTIs, but they did say that she's had decreased urine output, and her urine has been very dark and strong smelling. As far as her mobility, she usually can get up with an assist of 1. She's fairly strong on her right side, but still is very limited on her left. So someone is wanting a UA, that's great. You're also thinking UTIs, that's good. So what interdisciplinary communication should occur at this time? Anybody else you should be talking to? Should be trying to get the IV, definitely contacting imaging in the lab, yes, radiology. We already talked about talking to the extended care facility. May also need respiratory therapy, good. One thing I actually just thought about is, what about her family? Maybe her family could give us some information as well. Eventually, she's going to need a rehab consult. Good, Brad. Social service. All right, now let's talk about what labs would you expect to be ordered? BUN, creatinine, CBC, electrolytes. Good. Someone had already said a UA. And as far as all of the imaging goes, someone had said radiology for the hip and a possible head CT. That's good. What about maybe her elbow as well? She does have an injury to her elbow. Any other treatments that she needs? Hydration, good. That's really the main thing right now. Until we get some of the results back, hydration's the main thing. Sarah's asking, could she be at risk for some type of infection, infection risk for sepsis? Absolutely, anybody could be at risk, so maybe doing a sepsis screen would be a good idea. If you all have sepsis screens in your health records, or even, I know you probably remember whenever we were at your places before, if we did sepsis, I talked to you about being able to do a sepsis screen in your head. So being able to look at her and say, okay, we know she's tachycardic, she's tachypnic, we know she's had decreased urine output, all of these things, so we know that she could have a possible positive sepsis screen. So if she has a positive sepsis screen, what are we going to do next? Anybody? Hydration, antibiotics, anybody else? Close monitoring, order a lactate, good. So all of those things we would be doing. So adding that lactate to the labs would be a great idea. SCDs if unable to ambulate, perfect. I knew you guys would think of things that I didn't think of. So let's go ahead and move to the next slide, JJ. All right, pain management, good job, Sarah. Definitely. That was something that we probably should have hit on harder, was her pain. Let's go ahead and watch scene 3 and see what happens.
This is Sandy Withers. She came to us from the nursing home. She is 67, history of CVA, hypertension, COPD, CAD. She has left-sided residual and dysphagia. She does have a PEG tube. She's been getting all of her nutrition through. She fell this morning. They found her down next to her bed. She says she didn't hit her head. She's not complaining of any head pain. Sure. She has pain in her left hip, and she's got quite the hematoma there on the left hip, and then she also has a skin tear on the left elbow. She does complain of some pain in the left elbow, but not whenever I actually touch the joint. She's been alert and oriented, but just kind of tired, lethargic. I tried to get an IV in her right forearm. I was unable. I need to try again. She's got, other than the trauma skin issues, she also has a pressure ulcer on her coccyx.
Okay. How are you, Miss Withers? I'm Dr. Rizzo. We're going to be taking good care of you, okay?
Okay.
We're going to take a look at you and then we'll get some orders in, okay? Let me get some gloves real quick, alright?
Yeah.
She's going to try and start another IV on you, okay? Yeah. How else she feeling?
Tired.
Tired? Are you hurting anywhere besides what she said?
No.
No. Head's not hurting or anything?
No.
Do you remember why you fell?
I wanted a glass of water.
Okay, well let's look at your elbow real quick. Yeah, you definitely got a skin tear there. Is it still hurting pretty good? Okay. How's your hip? Okay. All right.
Hey, Sandy. I'm gonna look for another IV, okay, hon?
Alright.
Anything up here hurt?
No.
Okay. All right. Can you wiggle your feet for me? Okay. All right. Everything else okay?
I'm tired.
Tired? Okay. All
All right, dear, we're cold again.
right. They've been giving you your feedings?
Mhm.
Yeah. Okay. Do you know what time she fell?
She was found down when they went to get her out of bed around 7.
Okay. Were you able to move your hand at all? Squeeze my fingers?
Just a little.
Okay. Awesome.
I had a stroke.
Right, I know. Is your arm and leg both affected the same? Okay. All right. We're gonna go ahead. We're gonna get an X-ray of your elbow and of your hip. Okay.
Mhm.
Let's go ahead and get a CT of the head too, just in case.
Okay.
We'll rule out trauma there as well, and we'll get this IV and we'll get CBCs and CMP done. We're just gonna draw some blood and we'll check it for you. Okay.
Okay.
All right.
All
We'll
right,
check.
big stick, hun. Ready? Here we go. I'm sorry, babe.
If she's not able to get that, I'll try for you. Okay. We got to get some stuff started.
Okay.
All right. We want to make sure and take good care of you. Are you allergic to anything?
No.
Okay. All right.
That's blue.
Okay. Let's take a quick listen. Can you take a deep breath for me?
I'm so sorry, honey.
Sure.
All right.
I tried with the 21st.
Okay. I may
22
come
that
over here and
time.
try and get some in her hand for you. Get that to stop bleeding. We'll take a look real quick, okay?
Right.
Size 1.
I'm sorry. We'll go with another 20 and we'll see here once we get this checked. We're gonna clean your hand up, okay?
Okay.
All right. Okay, there's 20. All right, little poke, okay?
Okay.
1, 2, 3.
All right, so Dr. Rizzo was unable to start an IV as well. He tried twice. He did go ahead and put orders in for trauma series of the left upper extremity and left lower extremity, CT of the head without contrast, CBC and a CMP. He wanted us to obtain IV access and start with a liter normal saline bolus and do a straight cath for a UA. So how do you feel about the orders? Do you feel like the orders are adequate? Going back on the last comment and what we talked about before watching the scene, we did not get an order for pain management. So that's something that should have been addressed from the nurse back to the physician, was that our patient was in pain. Do you feel like the 1 liter of fluid was enough for our patient? Anyone have any thoughts on the amount of fluid? It's probably a good starting point, right? So Sarah says that we probably need to see what the labs show before giving more. It's a good point. We don't know, does she have an infection? Is she septic? Is she just dehydrated? What's going on? So doing a little follow-up here, how much does she need if she were septic? What's the one piece of information that we need to get to determine how much? Correct. Alyssa said we need to get her weight, and she is 90 kilos. So if she's 90 kilos, you don't have to do the calculation, but how much fluid does she need for a septic patient? Anybody remember or know from your protocols? 30 milliliters per kilogram if she were septic. So the fluids are determinant on what is going on with her. So we need to get the labs, but it is not a bad idea to get some fluids started. So what do you do if you're unable to obtain IV access? What would you do in your facilities? Sarah says IO. Alyssa says PIC. Alyssa, do you have a PIC team in your facility, or do you have to call a team in? Alyssa says they call a PIC team in. Okay. And she also says that the patient has a PEG. Yeah. She has a way of getting fluids into her body. It may not be our preferred route, but it's a route that we can get some fluids into her. So that is one option. Whenever Suzanne gives her presentation here in a little while, she is going to talk to you about amounts and types of fluid and what you should give according to how dehydrated the patient is. We're not going to get into all of that yet because that's part of Suzanne's presentation. So what can we do for Mrs. Withers at this point? I think Alyssa hit it right on the head, is we can give her some fluids in her PEG. And we can also make sure that she's comfortable and not in pain. So it's now 9 o'clock. Our imaging has been completed. The lab work was drawn, but with some difficulty. And we did a straight cath, and it produced minimal, only 25 milliliters of dark tea-colored urine. 9:30, we got some results back. UA is still pending, but there's no abnormalities in any of the imaging, so that's great. And the next slide will show us our labs. Oh, I hope you can see that. So just at a glance, we want to look at our white count. It's 9.3. Hemoglobin 17, hematocrit 52. Bands are 1. Our BUN is 25, the ratio of 25 to 1. Creatinine 1.3, glucose 88, potassium 4.8. Sodium 146. What are you noticing? Anything abnormal? From looking at our labs, do you think she has an infection? Her white count is within normal limits. What about her sodium? She's got an increased BUN creatinine ratio, and an elevated sodium. So what's that tell us? She's dehydrated. Let's go ahead and watch scene 4.
Sorry, Sandy. I know it's sore. Hey, Dr. Rizzo.
Hello.
Carrie tried to get some IV access as well.
Okay.
We've still been unable to get an IV. Do you think maybe we could get the PIC team to come in and try to get a PIC?
I don't think we'll be able to get access to the PIC team due to the holiday weekend. How about we start her with a liter of sterile water through her PEG. It's do 250 mils every 6 hours. We'll see about getting somebody to try an IV after that.
Okay. Alright. Now, do you want that instead of her feedings, or?
No, do that in addition to her regular normal feedings and flushes. We're going to go ahead and admit her, and I'll call the hospitalist.
Okay.
Okay, so our current orders are to give a liter of sterile water through her PEG in divided doses of 250 milliliters every 6 hours as tolerated. She's going to go ahead and get her feeding started, and we're going to attempt IV access again after she's gotten some fluids through her PEG. She is going to be admitted to a medical floor under the hospitalist service. So how do you feel about Mrs. Withers' care? Sarah is not happy. She needs pain management. So first thing we do whenever we talk to the hospital is just get pain management, right, Sarah? So other than the pain management, how do you feel about Mrs. Withers' care? What did we do well? I thought that you guys did really well of realizing, okay, we're not going to be able to get an IV, so we need to get an IO or a PIC or use her PEG. That was great. So Sarah's asking, about using the PEG, will it be enough to hydrate? Because it's going to take some time to hydrate through the PEG, I don't want to say that it's enough, because she needs, you know, if we were to give her fluids through her IV, we would give her, you know, 500 milliliters in, you know, 15, 30 minutes. But through her PEG, it's going to take how many hours? Probably 12. And that's in addition to her feedings and her regular flushes. So she is going to be getting more than that. But it is what we have available. If we were to call in the PIC team, that doesn't mean that we would get access any quicker than that. Does anybody have any experience with that? How long you have to wait for a PIC sometimes? Now, so Sarah's saying that their PICs, they can get in 2 hours. That's amazing. That's really awesome. Now, putting in an IO, that actually is extremely quick. Alyssa says their teams are there within a few hours. Guided ultrasound IVs, that's a great idea as well. Good. These are all ideas that we were hoping would come up. Using those critical thinking skills. Does everybody on here have the capability of doing guided ultrasound IVs, or does not have access to a PIC team or an IO? I can tell you that we have been places where it's an issue, where they may have to wait for a PIC. So that's why, and hopefully everyone has access to a guided or to an ultrasound machine to be able to start IVs. But I just don't know for sure across our whole cohort. So what do you think is the underlying condition of our patient? Why is she dehydrated? Is the PEG doing what it's supposed to? Do you mean like, is it in the right, is the placement correct maybe? Or maybe is something wrong with the PEG, or is something wrong with the protocol for the PEG? Or the orders for what she's supposed to get in her PEG? There, Alyssa's saying, has something recently changed with her orders for her PEG? What else could cause dehydration? Medication changes, good. Maybe she recently got put on a diuretic, or yeah, like Lasix or hydrochlorothiazide. What if all of a sudden her kidneys aren't working like they're supposed to? Her labs looked okay, but what if all of a sudden she has another condition going on? So come to find out, Mrs. Withers ended up spending 5 days in the hospital total to get rehydrated. She ended up getting an IV placed after she had received some fluids through her PEG. She was rehydrated enough that we were able to start an IV. Whenever she was getting ready to be discharged back to the extended care facility, it was discovered that her routine free water flushes had been left off of her record a couple weeks prior to her hospital admission. So whenever they were transferring orders over, something got missed, and she hadn't been receiving the water that she was supposed to be receiving. Mrs. Withers, she had been receiving her feeding and small flushes to clear her tube out after her feedings, but that was it. While she's still very weak and tired, she's now on her way to recovery. Anyone have any thoughts? Closing thoughts or comments on our simulation? Okay, well, thank you so much for your participation. It would not have been the same without it. And next up is Suzanne Wheeler.
Laura, that was really excellent. I really enjoyed the simulation. That was really good. So we're just going to spend about 20 minutes talking about causes of dehydration in the adult, some physical assessment and laboratory findings, and different strategies to treat it. So dehydration is a very common diagnosis, not only a primary diagnosis on admission to the hospital, but also secondary. And the numbers are growing. And that's partly because we have an older population across the world. And also our environment has been changing some. In fact, in France a few years ago, their mortality rate shot up the summer they had extremely high temperatures. I know last summer it was very hot there, and I haven't seen anything about those statistics, but I think it was about 5 or 10 years ago they had a very hot summer and their mortality went really sky high from dehydration cases. AHRQ, which is our healthcare quality group in the United States, they list dehydration as a top preventable diagnosis. And in the long-term care and extended care facilities, this is actually a sentinel event if a patient becomes dehydrated. So it's very important because the elderly particularly are very much at risk. Dehydration itself has a very high morbidity and mortality, which I had not really realized. I knew that it was bad to get dehydrated, but research coming out really recently is showing that for all of us, long-term subclinical dehydration is bad for our organs and has been connected to some kidney injury. So that's not good. So first thing in the morning, get your water or your fluids, or first thing on your shift, get your fluids ready to roll. I had a nurse teach me that, and I don't always get it right, but it's an important thing to do. And it's expensive. You can see $1.6 billion in annual hospital-related charges related to dehydration. And there's been several big studies on this and Cochrane reviews and different things. A couple groups went out and looked at community patients or community adults and also adults in the extended care facility and found that 40% were underhydrated or they were almost to that dehydration stage, and 20% were clinically dehydrated. And we're talking about all the older adults. These were big studies. Doesn't it make you thirsty just talking about it? I've been so thirsty researching all this. So what is it? It's a loss of body water with or without salt at a rate greater than our body can replace it. And that can be from a decrease in intake or an increase in losses, or it can be a combination of both. And you can also have relative dehydration. And we've all seen this in patients where they fluid shift, especially after big surgeries or after big traumas. Patients that have they shift with ascites and they just tank, and they can get very hypovolemic from that relative dehydration. So this is a list from Laylor about causes of decreased intake and causes of loss in our patients. And so there's lots of them, lots of causes. And we'll talk about more specifically in a little bit. So we are bags of mostly water. I'm a Star Trek fan, and I remember in the original Star Trek, an alien saying to Captain Kirk and Spock, "You are bags of mostly water." And I thought it was really funny at the time. But then when I found out that when you have more fat than maybe you should, more fat than muscle, you don't have as much body water and you're more prone to getting dehydrated. And that makes me even thirstier because of my my obesity issue. Also, as we get older, we lose our body water. And we know that folks that are elderly are very much at risk for dehydration because they don't have the brown fat. They're always cold, so they crank up the heat. They don't want to drink. And it's a real issue. Plus, they have all these comorbidities. So we start off 70% water. As we become an adult, 60% total body water. And then as we become an elderly person, which is around, they classify that at above 70, 75 years of age, we're down to 50 to 55% or lower, depending on our composition of our body. So what causes dehydration? It can be acute or chronic. And you can think about folks that have acute C. diff and having that extreme watery, constant diarrhea. And they don't feel good, so they're not drinking. And boy, they can get dehydrated really fast. They could have another chronic health condition. Suppose that you're getting cancer treatment and you had stomatitis and your mouth hurt and your throat hurt and everything hurt, and you were on chemo, so you had you felt sick, you were vomiting. So there's many things that contribute to dehydration. Anything that causes you not to drink enough water or not to get enough water in your PEG tube are all causes. Environment. I know that with my folks, my father, who was in his 80s, every summer he'd go outside and sit and get dehydrated. People that don't have access to fluids or who can't control their fluid intake or at high altitudes are more prone to dehydration. Any kind of increase in exercise, you got to be sure and replace those fluids. Medication changes, you guys talked about a lot of those when you were talking about the simulation, but there's lots of meds that can make your temperature go up. There's meds that can make you diurese. Beta blockers can change your volumes. There's just lots of things. I was going to say laxatives as well. Any kind of anticholinergics or those kind of things that reduce your thirst or change your thirst, or those conditions that change it. Any kind of mobility changes or any kind of dietary or fluid restrictions. So recently, there's been some research done into dehydration and the fact that there's really two clinical syndromes going on. And sometimes you start with one and you go to the other one, kind of like our patient did in the simulation. So dehydration in the simplest terms is an increased loss of body water. And most of the time for a patient that doesn't have any other kind of health issues, their serum sodium will go up. And again, it's due to those things we talked about. Volume depletion, that's hypovolemia. So if you're dehydrated and it becomes severe, now you also have hypovolemia or volume depletion. But volume depletion itself can be caused by a big hemorrhage. It could be caused by a big GI loss or third spacing. Those patients with acute pancreatitis, they can shift fluids really quickly and become hypovolemic. And septic patients that become vasodilated and they shift the capillary leak and they shift their fluids as well, and that causes hypovolemia, which we know is life-threatening. So you can be dehydrated, and a simple dehydration would be, let's say, not simple per se, but could be caused by severe diarrhea. A volume depletion could be because of a trauma where you lose massive amount of blood that causes shock and hypovolemia, or you could have both. And examples of that are in folks that have cholera who have this, or C. diff, and it turns into, eventually they start with dehydration and it becomes volume depletion and hypovolemia, and they get hypovolemic shock. So this is from that same research study by Assam and all in 2019. And they're just saying that for a dehydration, you have loss of water, your sodium goes up and your tonicity of your blood goes up and you get thirsty. That stimulates your thirst center if you're able to get thirsty. Elderly folks don't have that capability sometimes. They don't feel thirst. And so that's why they're really at risk. And so here's the feedback loop that causes us to increase our water, hold on to our salt, etc. If our kidneys are working good, they do their part, and we excrete from our pituitary that antidiuretic hormone to hold on to fluids. And we can take a drink and replace our fluids, get back to normal, hopefully. In extracellular fluid volume depletion, this is this patient that has a massive hemorrhage from whatever source, and they not only lose water, but they're losing blood, plasma that has salt in it too. So now they become hypotensive, and they start to show those signs of orthostatic hypotension. They get really tacky. Their urine output goes down because they're not getting perfusion. Their lactate goes up, and there's kind of a different look depending on the cause of these fluid losses. So I guess the point I'm trying to get across is that it is complicated and it looks different depending on what the cause is, how long it's lasting, what the baseline of the patient is, etc. So the signs and symptoms really vary, and there has been a big Cochrane study into this and a systemic a review, and they've looked at what kind of symptoms and signs do people have. Well, they have just about anything with dehydration, but a lot of folks, if they're older, one of the first things you'll see is delirium. So a change in that mental state. One study has found that a pulse rate of greater than 30 from supine to standing has been a big issue as well. So you can look for that. Again, it might depend on the type of fluid loss and how quick. And Laura went through a lot of these already, so I'm not going to spend a lot of time on this. I did think it was interesting because this is one of those questions that I often have gotten asked, or I've often wondered. For adults, if you have a fever greater than 103, then you are really losing fluids and insensible losses, and you need to get help right away. And that is a CDC guideline. Now, kids we know are different, but we're talking adults today. So severity of dehydration, it really kind of changes based on how much you've lost. And you can really use weight. If you have an accurate baseline weight and you can accurately track weights, you're looking for that change in daily weight. That's the best indicator of fluid losses and gains. So if the patient has lost 3 to 5% of their body weight in 7 days, that's considered mild dehydration. 6 to 9% is considered moderate dehydration, and greater than 10% of your body weight is considered severe dehydration. They need to be admitted. They're hypovolemic. They're at risk for death. And it goes like that. Remember, lethargy, seizures, coma, death, if they don't get treatment right away. So for mild dehydration, they may have no signs and symptoms of change in mental status. They may be alert. A lot of people complain of a headache or feeling irritable or restless. Once they get moderate dehydration, now you're starting to see that dizziness. They may stand up and get dizzy. They may have some slight change in their mental status, some lethargy, maybe some confusion. And then as they get more severe, now you've got the lethargy, it's hard waking them up, they're confused, they're drowsy. Again, they need fluids fast once they get to that above 10% of their body weight. Again, over 7 days is what we're talking about. So if you have mild dehydration, you're looking pretty normal, except maybe that slight headache. You may be thirsty, but it's not critical yet. Your cap refill and your skin turgor, not always great signs, not always accurate, but in this situation, they would be normal. And then as you go through to moderate, now the patient has delayed skin turgor, prolonged capillary refill. They're very dry. Everything's crusty. They have crusties and furrowed tongues, and it's not good. Their urine output now is down. And then for severe, everything just got a lot worse. Now they're going into shock. They have prolonged cap refill and skin turgor, and they may start off warm and hot, and then as they decompensate, then they may go into that cold and clammy vasoconstrictive stage, and minimal to no urine output. So not good. So older adults are really at risk, and we talked about some of that already. But I just wanted to mention, I thought this was really interesting. There was a study done by Mentes, and she's a nurse practitioner, I believe, in Texas. And she has been studying dehydration in extended care facilities and long-term care for quite a long time. And she calls the patients those that can drink, those that can't drink, those that won't drink, and folks that are terminally ill, and it's very difficult for them to drink. And she said the folks that won't drink and can't drink are really high at risk for dehydration, because, you know, they're sippers perhaps. And it's often missed in the older adult. And I know from my own parents that they don't want to drink because they have incontinence problems, or my dad had prostate problems. And so they were both on Lasix. So that was the main reason they did not want to drink, because they did not want to have to go to the bathroom. And they were very embarrassed about it. And again, older folks are on a lot of medicines, and they have all kinds of challenges with vision and hearing and ability to reach the water. They may have dysphagia. So if you have a patient that has had a stroke and has dysphagia, they're one of the highest folks at risk for dehydration. So are folks with renal failure and heart failure, because we're so afraid of overloading them with fluids that sometimes they get underhydrated because of that. This is just FYI, but this is a dehydration risk appraisal for folks in a nursing home or extended care facility. So this is a great way to look for older folks that are at risk, or anybody that has comorbidities that's at risk. And you can see the older you are, females have less muscle, so they're more at risk. Anyone that's been dehydrated in the past or has had repeated infections, they're really at risk for dehydration as well. And anybody with a PEG and dysphagia, or they can drink but they forget, those are all people at risk for dehydration. The greater the number you check, the higher the hydration problems. So in the hospital, why are they at risk for dehydration in the hospital? There's so many reasons. And the patients are often in PO, and they're having tests and things. And sometimes they come in and we're waiting for a surgeon to consult. So we keep them in PO because we think they may be going to surgery, etc. They may be on a restricted diet or thickeners, and they don't like it, or they need help with it. I know some hospitals have had sterile water shortages, and they don't want to use their tap water. And so there's been some issues with getting those flushes. And it's also possible that the patient came in for something else and they were already dehydrated. Or maybe they've been in the hospital and they had surgery, and we just could not get them back to baseline with their hydration status. Also, the whole feedings with the pumps and the flushes, sometimes the orders don't get put in correctly, or sometimes they're not appropriate, or sometimes the machines don't work. It's like everything else, we have to keep an eye on those water flushes and make sure that we have dietary and or pharmacy consulting on that, and working with our team to get the right amount on that. We may have drainage, wounds, burns, and we may have patients that are just basically leaking from everywhere. And you know what I'm talking about. They're weeping, they have really high amounts of saliva, they have draining, they may have constant bleeding, fever, just lots of things. And people that have hyperglycemia or diabetes insipidus, they can lose a ton of fluids fast. So different things in the hospital, especially, we give medicines that can lead to these things, like mannitol, different things like that. So what are the complications in the hospital, or really any setting of dehydration? UTIs, kidney stones, acute kidney injury, pressure ulcers. And you notice that the simulation patient already had a pressure ulcer, because we're taking away some of that body water, which helps protect. Confusion and delirium, etc. That might be the first sign you see in an elderly person, or a fall. may be the first sign you see. Constipation and respiratory infections, because again, everything's getting dried up and you're not as able to clear your respiratory tract if you're dehydrated. So lots of things. So clues to clinical presentation, and we've talked about a lot of these already, so I won't spend a lot of time, but that weight loss is an early indicator. Remember, when weight comes off fast, it's water, which I find incredibly depressing when I'm trying to lose weight. And everyone tells me, well, that was all water. Oh, but you gotta, I guess that's just how it goes. But also folks that have changed their environment, increased their activity, for whatever reason, their mouth or their teeth or their throat isn't working well. So you want to find out what's changed. And a lot of folks cannot tell you what they've had in the last 24 hours. And so sometimes you may not get that information, but you can tell based sometimes on their mouth how dry and et cetera it is. But those are just some clues to our care. Again, we've covered this already, but just to kind of put it in our physical exam format, just looking at those different things. Some patients have sunken eyes, but not everyone does. Again, it all depends on how long they've been dehydrated, what the cause is, and what their baseline was, what they're going to kind of look like. One thing I did want to mention is normally when you hang your hands down below your heart, your veins on your hands should fill. So you can check that with your patient. If you're hanging down their hands and there's no filling, maybe their rings are real loose, their clothes are loose. Another thing is you want to check their jugular veins to see if when you lay them flat, if they fill, because that's normal. If you lay a patient flat or supine and their jugular veins don't fill, that's a pretty good sign that they're dehydrated. Another thing you can do is raise up their legs and see if raising up their legs helps to fill their blood vessels and increases their blood pressure and decreases their pulse. So those are just some tricks. Remember, a patient may have lost a ton of weight. You know, in 7 days, they've lost over 10% of their weight, but they have this huge stomach. And that could be due to ascites. So they may have shifted a lot of fluid, and what they've lost is muscle. So keep that in mind as well. Labs as well will vary according to the type of dehydration and the cause, whether it's mild, moderate, severe, and what has caused the dehydration. But these are typical labs, especially for someone that has normal kidney, liver type of things. They will get hemo concentration. So you'll see, like in our simulation, they'll get that crit above 50%. Their MCVs will go up because they have all these cells, but they don't have as much of the plasma now because their patients kind of dried up a bit. Serum sodium may go up with water losses. Again, if they've lost a lot of blood, the serum sodium may stay normal. It just depends on the cause. But this is kind of a basic guideline to go by. The big one is the BUN and creatinine ratio. It's an early sign of dehydration in most people that have a healthy kidney, that is. So that's a real warning sign if you see that. So in other words, their BUN's going up, but their creatinine looks okay. So that ratio starts to widen and go up. Another clue in a patient that may have kidney problems is that their BUN starts to go up, and you're tracking that rising over time. That's a clue that they may be having dehydration. And then a patient that a patient that gets a really high creatinine is really only seen in a patient. I'm talking about a patient without kidney injury or that doesn't have renal failure. If their creatinine is high, you'll see that in severe dehydration related to the acute kidney injury that's happening from that low perfusion. Remember, the kidneys love fluid, just like the brain does. So there are early indicators. Some people use serum osmolality as a gold standard for assessing for dehydration. So you'll see that osmolality go up, and it'll go up above 300 or even above 295. And that's often because the salt has gone up and the fluid in the body has gone down. So in other words, they have a high tonicity, and the specific gravity is often up, and urine osmolality may or may not be up. Urine sodium often is low because the body is trying to hang on to it. Okay, so again, this really varies depending on what the cause is. This I thought was really interesting. Again, this is from Mentes. She's done a lot of work on dehydration, and her point is we need to stop dehydration before it happens, because we know dehydration is associated with bad patient outcomes and readmissions and all kinds of problems, and kidney failure, which is never a good thing. So her point is, if you see a patient that has kind of these impending dehydration labs, we need to get on it. And maybe the thing we notice is they're not making that much urine that they should be. And I thought this was a really, really good point that she shared, that we don't want them to get dehydrated. Let's stop them before it happens. Treatment and interventions. First thing we have to do is our ABCs and get our patients safe. And if they have severe dehydration, we have to do resuscitation fluids. And that is through our, most typically through IV fluids. Again, that could be IV or IO. And of course, if we can't use either, we have to use either a PEG or oral. Sometimes you have to give the patient some drinks so you can find the veins. Then after we give the resuscitation fluids for severe dehydration, get them stabilized, then we need to figure out how much they've lost and start those replacement fluids. So again, if they have mild or moderate dehydration, we would probably start with the replacement fluids. But for severe hypovolemia, dehydration, shocky, not good kind of thing, we've got to give those boluses fast. So we replace the losses with replacement fluids. Then we start our ongoing supportive fluids, which are called maintenance fluids, because we lose a lot of fluid normally every day. We have to support those as well. And if the patient's in the hospital, they have other losses they don't normally have. They're breathing faster, they may have a fever, they may have a wound, we've changed their meds, etc. Of course, we're going to work on stopping whatever the cause is as soon as possible, or supporting them, augmenting, whatever treatment we can for that. Accurate I&O, it's hard to do, but really, really vital, and all our hospital patients are at risk. And also those serial weights as well. Urine assessment and tracking, again, we're trying to make sure they're getting a minimum, if they're a non-critical patient, a minimum of greater than 1,200 a day. Of course, if they have renal failure on dialysis, those kinds of things, we have to adjust for patient individuality, those kind of things. And then when we're doing our fluids, we got to make sure they're tolerating it. And what is their response? Are they getting better? Are they starting to get into some fluid overload? Are they getting worse? What's happening? So we'll have to keep monitoring them as well. So replacement fluids, again, if they have mild dehydration, we can give this orally or enterally, depending on what they have going on. If you can't get access, though, they may have to get it some other way. Moderate dehydration, start off oral or enteral as tolerated. If not, or if you can't get it in fast enough, you may try hypodermoclysis, which is subcutaneous rehydration therapy, which is becoming quite popular in some areas. I have never done this before. In fact, I had never heard of it before I started researching the treatment for dehydration here recently, and I'm curious to whether or not anyone has seen this or heard of this done. Apparently, it's quite popular with peds and also with some of the elderly who may or may not tolerate it as well as children. And then also IV replacement fluids. Most of the time, these folks can get these fluids in the ER or in outpatient treatment or in the IV lab, those kind of things. May or may not have to be admitted. If they have severe dehydration, they do have to get admitted, at least for overnight, and get those fluids replaced and maintained, and also check out other losses they may have, like electrolytes, etc. what type of fluid that the patient gets as far as IV fluid or sub-Q fluid or IO fluid depends on the type of dehydration. Of course, if it's blood, you're going to give them blood according to how much they've lost, etc. Most of the time, though, crystalloid is the mainstay for early treatment for resuscitation and also sometimes for early replacement IV fluids for that severe dehydration. If it's not severe and you have a little bit of leeway and you're afraid that the patient may not need things quite as fast or may not tolerate them, they may do some saline or LR initially, and then they may switch it to D5.5 normal or a D5 normal so that the patient also gets some glucose with that as well, depending on their history, etc. It also will depend on clinical findings and histories, or if they have heart failure, kidney function, liver failure, other comorbidities, etc. And there's a picture there of the sub-Q IV fluids, which I thought was really interesting. And apparently, this is also a treatment for cats or animals that get dehydrated. Interesting. I don't think my cat would have approved, but if they're really dehydrated, they may not care. So this is an example of a fluid replacement calculation guideline for older adults. And this is from the American Medical Directors Association, who published a book in 2009 with guidelines for treatment of older adults, and specifically for those folks that are in extended or long-term care facilities. So if your patient, this is from their guideline, if the patient has lost 4% or greater of their weight within 7 days, then that is most likely due to acute dehydration. And you need to treat the cause and then begin administering, if able, oral fluids over 3 days. And of course, if they had a PEG, you would use that, or a G-tube. And the way they calculate that is they take the pre-illness weight in kilograms and they subtract it from their current weight. And then that is your deficit in liters. And so then that's how you can figure out how much fluid to give the patient. So on day one, you give them 50% of their replacement fluids. And you also give them their daily maintenance fluids of 1,500 milliliters. So this is what they would get for maintenance. And then this is the additional replacement fluid they would get orally or through their PEG. And then on day two, you quarter that. And on day 3, you would quarter that. And they claim, based on their research, that on day 3, their weight will be close to what it was pre-illness. So I thought that was kind of interesting. There are lots of different calculations for fluid replacement. And unfortunately, not a lot of them are evidence-based. And Parrish et al., it's an excellent article by them, physicians and GI docs, and they put out a great article about how to take care of patients with enteral nutrition. And they said that hydration calculations may not take into consideration clinical assessment of the patient, their comorbidities, and their insensible losses. I mean, if they're on a ventilator or if they're breathing fast or they have wounds, etc., those hydration calculations may not take that in consideration. So they recommend replacement fluids. If the patient is NPO and unstable, give IV crystalloids times 2 liters over boluses of 500 for 15 minutes, assess, response, and tolerate. So you're going to give them 2 liters of crystalloids fast, essentially. If you're worried about how they tolerate it, again, you give 500 and you assess the patient. You know, what's their lungs sound like now? What's their vitals? What's their mental status? Cap refill, all those different things. If the patient is stable, they recommend giving a slower mixture of D5.5 normal or some kind of, also they said normal saline or LR. This is just an example of what the orders might look like. D5.5 at 75 an hour for 2 liters. More of a slower replacement. Meanwhile, you're still giving them their enteral water and their enteral feeding as well. And then a caution, if their serum sodium is low, You're going to give them water. You can give them water into their PEG or their G tube. Again, you can't put a ton in there or they're going to feel sick and maybe vomit and possibly aspirate. So you have to, like Laura said, you have to divide it up. And they suggest either 250 milliliters every 6 or 165 every 4 hours. If their serum sodium is greater than 150, then you got to go to the IV hydration. And it may be that you have to use some D5 water with a controlled delivery, because you want to give them more of the water as opposed to the isotonic, more of a hypotonic fluid. And you never want to give that too fast, because that can cause encephalopathy, brain swelling, and different other bad things. So you have to give that controlled in that situation. Again, it all depends, according to their guidelines, on according to these authors, on how stable the patient is and whether or not you can use their PEG or their G tube to give them fluids as well. Most of the time with these patients, you're doing a combination of things, kind of like in our simulation. And then anytime that patient with the PEG is NPO, they recommend a maintenance drip. And maintenance drips are usually either 75 cc's an hour or 125 cc's an hour. And that's because that's based on how much fluid that we normally lose in a day, which is around 2,500 cc's per day. That's why we give those amounts. And I did not know that. And I always wondered, now, how did they know to start that maintenance fluid at 75 an hour? Or how did they know to put that at 125 an hour? Isn't that a lot of fluid? Well, come to find out, it really isn't. That's just normal intake for that patient that can't drink, because you're still losing stuff, even if you can't drink. And again, as Laura said, we definitely want to do an interprofessional, interdisciplinary approach and work together on this, because it's complex. Okay, so dehydration, challenging. And in the literature, again and again, they speak to the fact that there's no real universal definition for dehydration. There's so many different things that can cause it, so many presentations. It happens to everybody, like sepsis. There's no standard process for assessing. It's difficult sometimes to assess. So if you have a doubt, you want to maybe get some labs, because the clinical signs and symptoms may not tell the whole story. The other thing is we want to use all of our data, our history, our physical exam, our labs, our evidence, and our patient's individuality to come up with our different questions we want to ask and what we want to do. So putting it all together, we want to definitely identify those high-risk patients. Again, a lot of patients coming into the hospital are already dehydrated or are at risk for becoming so while they're there. Initiate a fluid assessment policy. Over in the UK and in Australia and different places, they've been doing a lot of work on implementing fluid assessment policies and reminders and trainings with staff. For example, during the hourly rounds, you want to make sure that oral care, assessing for thirst and giving drinks or flushes, etc., are part of that. And that whole, again, interprofessional team approach. And that's all that I have. I did include some resources for you that you'll have available on our website. This is from the UK, from the NICE organization, which is the National Institute for Health and Care Excellence over in the UK. This is their guideline for dehydration, which I thought was really cool. And then just some other information about, I just thought was really fascinating, about losses and I's and O's and those types of things. So that's all I've got. Over to you, JJ.
we can go ahead and end the session. And I thank you very much for your time today, and have a very good weekend.